Good evening, students. In this video, we are going to discuss a clinically very important topic called acute renal failure, often called acute kidney injury in medical texts, right? So, what actually is acute renal failure? It is sudden deterioration in renal function. Sudden, but in many cases, reversible deterioration in renal function, which happens in the duration of like hours to days, right? The main criteria of how we diagnose acute renal failure is that rise in serum creatinine level more than 0.3 gram per deciliter over a period of 48 hours, right? So what are the things which can lead to acute renal failure, and what are the things which we are going to find out in acute renal failure, right? We are going to discuss the overall mechanism of acute renal failure in this video, right? So basically we divide acute renal failure into three varieties, three causative varieties like pre-renal, intrarenal and post-renal, right? So pre-renal, let's start with our pre-renal cause, right? So the afferent arteriole is coming over here, right? And it is getting distributed into many small glomerular vessels, right? So pre-renal means that there is some cause before the kidney. That means the blood which is coming over here, right? There is some cause in the afferent blood vessel, or all the supply which is going through these afferent blood vessels, right? So due to some reason, right, the blood flow is less, right? The first reason, of course, can be hypovolemia, right? Hypovolemia can lead to less blood flow, right? Right? This hypovolemia, right, in turn can be due to many causes, right? This can be due to hemorrhage, right? Or due to loss of fluid like diarrhea, right? GIT, loss from GIT, right? Or it can also be due to, what to say, one thing is volume is less, other thing is that loss of effective circulating blood volume, right? In many conditions the overall volume is normal or even high, but the effective circulating blood volume is reduced in some conditions, right? Let's write in short form: effective circulating blood volume, right? This is reduced in some conditions, right? Most important condition is heart failure, right? The blood volume is normal, but heart is not pumping effectively, right? So the blood flow will be very slow in your renal vasculature. So kidney is going to think that there is less blood inside the body, right? So heart failure. Right? What other cause? One thing is cirrhosis. Now, how exactly cirrhosis will reduce your effective circulating blood volume? So what actually is happening in cirrhosis? In cirrhosis, you are having fibrosis of liver, right? So the blood which is flowing through the portal vein into the liver will find lot of resistance, right? Fibrosis and lot of resistance to blood flow of the portal vessels. So what is going to happen? The pressure inside these portal vessels is going to increase, the thing which we call portal hypertension, right? In case of portal hypertension, one very important metabolite is released, nitric oxide, right? If nitric oxide is released, it is going to dilate your splanchnic vessels, right? If your splanchnic vessels get dilated, all the blood will pool in your splanchnic vessels, and you will have less blood in your circulation, right? As simple as that. Cirrhosis means the fibrosis of liver, means less lot of resistance to your portal blood, portal hypertension, release of nitric oxide, dilation of splanchnic vessels, and pooling of blood in these splanchnic vessels, means less effective circulating blood volume, right? So kidney is going to interpret even your cirrhosis as less blood flow, right? And apart from that, shock, sepsis. Right? But how sepsis leads to a less effective circulating blood volume, right? In sepsis, there is one very important term used which we call distributive shock, right? Normally body has got a very intelligent mechanism of how much blood it wants to send where, which organs are vital, which organs are not that important. But in sepsis, that organization, right? That intelligent organization is gone, right? So you will have massive vasodilation in certain regions and lot of capillary permeability, right? This will reduce your effective circulating blood volume, right? Now, one obvious thing is your renal artery stenosis, right? If renal artery is stenosed, you will have less blood, right? Now, one clinically very important point over here is that certain drugs can also lead to acute renal failure, right? Now just think of it. The blood is flowing from this side, getting filtered out, right? And some blood is going out through your efferent arteriole, right? Now if you constrict your afferent arteriole, GFR is going to reduce, right? But one very important point is that this constriction is very important for maintenance of GFR, right? This constriction is contributing to the pressure inside the glomeruli. If you somehow dilate the efferent arteriole, right, the pressure inside the glomeruli is going to decrease, right? And you will have less GFR. So dilation of efferent arteriole is also not good, right? So there are certain drugs called ACE inhibitors, right? That's why ACE inhibitors are contraindicated in dehydration, right? Or in any condition in which the renal perfusion is already low, right? Suppose the renal perfusion is already low and you give ACE inhibitors to such a patient. What is going to happen? This is going to dilate. If this dilates, this GFR will get further reduced. GFR was already low and you gave ACE inhibitors to a dehydrated patient, right? So the GFR will fall, suddenly, okay? So in that case, ACE inhibitors can also precipitate your acute renal failure, right? In certain cases, NSAID can also precipitate acute renal failure. How? Suppose the blood flow is already low, right? And what these NSAID inhibit? NSAID are going to inhibit prostaglandins. But prostaglandins are something which keep these vessels dilated, right? So when the blood flow is already low, renal blood flow, and you give NSAID over that, it's going to inhibit prostaglandins and constrict your blood vessels, right, and precipitate acute renal failure. ACE inhibitors and NSAIDs. Right? Here we can also write dehydration. Right? So as per pre-renal is concerned, we have got so many causes, right? Less volume is coming, right? The less volume can be due to hemorrhage, can be due to diarrhea, can be due to dehydration. effective circulating blood volume has reduced, it can be due to heart failure, cirrhosis and sepsis. Even renal artery stenosis can also lead to acute renal failure. And ACE inhibitors and NSAIDs, right, can precipitate acute renal failure when the renal blood flow is already less, right? Now all these conditions the kidney initially will try to manage, right? There are myriad of mechanisms which will try to dilate your afferent arteriole and constrict your efferent arteriole, right? So initially the kidney will try to manage. And how it will initially try to manage? By the dilation of afferent arteriole and constriction of efferent arteriole, right? Dilation of afferent and constriction of efferent. Right? But just in case if this thing gets prolonged, right? If this thing gets prolonged, then these mechanisms are going to get overwhelmed, right? Prolonged, right? If this thing gets prolonged, these mechanisms will get overwhelmed, and what will happen then? Your PGC is going to fall, even your GFR is going to fall. If these two things fall, right, that means you got lot less blood coming, right? Then this can lead to ischemic injury, right? Ischemic injury of your PCT, right? Apart from that, what less GFR can lead to? It can stimulate your renin system, right? The renin system will get stimulated. Less GFR can also stimulate your sympathetic nervous system, SNS, in short form I will write, right? Less GFR can also stimulate the release of ADH. Right? And what all these three things are going to do? All these three things will lead to sodium and water retention. Now this is clinically very important. Clinically very important in case of conditions like heart failure and cirrhosis. This is going to start a vicious cycle, right? In heart failure and in cirrhosis, effective circulating blood volume is low, right? But what kidney is sensing it as low overall blood volume, right? So it will cause sodium and water retention, which is going to put even further load on a failing heart, right? The heart condition is going to deteriorate further, reducing the effective circulating blood volume even lower. This will cause even more sodium and water retention. So this creates a kind of vicious cycle, right? So this much is about your pre-renal, right? All this detail was about pre-renal. Right? This pre-renal can actually cause renal, intrarenal by this ischemic injury, right? Now, let's talk about what happens in intrarenal acute renal failure, right? Intrarenal type of acute renal failure, right? For understanding intrarenal type of acute renal failure, we first need to see PCT. PCT is metabolically the most active part of the nephron. And since it is metabolically active, it needs lot of oxygen, right? And since it is metabolically so active, it is the part which is most vulnerable to hypoxia, especially the S3 segment of the hypoxia, S3 segment of the PCT, right? The S3 segment, right? Right? So let's write intrarenal. What intrarenal is going to do? In intrarenal, we have got two varieties. One is ischemic and one is toxic, right? In ischemic variety, this S3 segment will undergo hypoxic damage. Right? And when this S3 segment undergoes hypoxic damage, what it will lead to, right? Now, even under normal conditions, the PCT is always on the verge of hypoxia because it is metabolically so active. So it is always on the verge of hypoxia. But just in case the blood volume falls, right? The hypoxia becomes a lot more pronounced. Now less oxygen translates into less ATP from mitochondria, right? So since the oxygen supply is less, this means less ATP. The production of ATP is going to reduce, right? Now what less ATP means? Less ATP means, that means now you have got less ATP for the running of sodium potassium ATPase pump, right? Now less ATP, sodium potassium ATPase pump function is going to reduce. And once this sodium potassium ATPase pump stops working, it will be absolute chaos in the cell, right? The sodium potassium ATPase pump will stop working. The cells are going to swell up, right? Because this is the thing which is pumping sodium outside, keeping potassium inside. If this thing is not working, right, the sodium will stay inside. The water will come from outside to inside. The cells are going to swell up, right? The cellular architecture will be lost, right? And polarity of the cell is going to change. Why polarity of cell is going to change? Because this sodium potassium ATPase pump will now migrate from the basolateral side to the luminal side. So there will be absolute chaos inside the cell, right? Sodium potassium ATPase pump will stop working, right? After it, what we are going to see? We will see cell swelling. Right? After cellular swelling, what we will see? Polarity of the cell will be lost, right? After that, what will we see? The cellular architecture will be gone, right? And amid all this chaos, right, what you will get is mitochondrial dysfunction, right? Your mitochondria will start dysfunctioning. And mitochondria, due to its dysfunction, is going to release the reactive oxygen species, ROS, right? Then there will be calcium dysregulation also, right? Calcium dysregulation. Now, due to this calcium dysregulation, you will have secretion of phospholipase and endonuclease. right? Now these reactive oxygen species, phospholipase and endonuclease, these both will combine and do one thing called membrane damage. The membranes will get damaged, right? Right? Now these reactive oxygen species, endonuclease, phospholipase, all these will do membrane damage, and this membrane will slough out, right? This membrane will slough out and go and block the tubules, right? And once they block the tubules, the intratubular pressure is going to rise, and this will further reduce your GFR, right? So what it will do, it will come over here, right, and it will block. These muddy brown granular casts are going to block your tubules, right? So muddy brown granular casts. Right? It's also called TAM horsefall proteins. Right? So what it will lead to, right? The intratubular pressure now is going to rise, and this is going to further reduce your GFR, right? So the intratubular pressure will rise, right? And this will further reduce your GFR, right? Then there is also one very important variety of intrarenal. We discussed one ischemic. There is also one very important variety of intrarenal, which we call toxic variety of intrarenal, right? Toxic. This toxic variety is also very important, clinically very important. When I was intern in medicine department, we used to see many poisoning cases, right? There are many patients who will drink the Vasmol, right? The hair dye, right? And what this Vasmol will do, that it will cause rhabdomyolysis of the muscle cells, right? And all that myoglobin will come, right? And gets deposited inside your tubules, leading to acute tubular necrosis. In case of massive hemolysis, there is some disease which is leading to massive hemolysis. So in case of massive hemolysis also, that hemoglobin will come get deposited inside the renal tubules, leading to acute renal tubular necrosis. Then there are certain nephrotoxic drugs like aminoglycosides. They can also cause acute tubular necrosis, right? So toxic, right? In toxic, we have got rhabdomyolysis, right? Apart from that, we have got massive hemolysis, right? Hemoglobin, right? So hemoglobin itself is toxic for your kidneys, right? So how come hemoglobin is toxic for our body? Hemoglobin serves our purpose as long as it is inside the RBCs. But as soon as it comes outside the RBC, it becomes toxic. That's why body always couples it with haptoglobin, right? So that to keep it circulating, so that it doesn't go into our tubules. But in case of massive hemolysis, this haptoglobin systems get saturated and hemoglobin reach our tubules and cause acute tubular necrosis, right? Rhabdomyolysis, massive hemolysis, right? And of course the drugs like aminoglycosides. right? So intrarenal has got two varieties, ischemic and toxic, right? But apart from that, there is one very important variety of your acute renal failure, that is post-renal, right? Now what goes wrong in post-renal? Let's draw our bladder over here, right? And our kidneys, right? So basically in post-renal, you have got obstruction either in your ureter, right? Or in your prostate gland gets enlarged, BPH, or ureteric stones, right? Or any constriction, fibrosis over the urethral opening, right? Constriction at the neck of the bladder, right? So basically anything which stops the flow of urine. The kidney is forming the urine, it can, any blockage anywhere, right? Be it ureteric stones, be it benign prostatic hyperplasia, or be it constriction at the neck of the bladder. Any blockage anywhere, what is going to happen, right? The pressure is going to increase, and all this excess pressure will be transmitted back to the kidneys, right? And your GFR is going to reduce, right? This is post-renal, right? Post-renal. And if GFR reduces due to these things, right? So of course it can lead to acute renal failure, right? But just in case, if you remove this obstruction, then you will get diuresis. Why you will get diuresis? Because all the solutes have accumulated because of the obstruction, and the filtering capacity of the kidney also gets reduced, right? So if you remove the obstruction, you will get post-obstructive diuresis, right? If obstruction is removed, then you get post-obstructive diuresis. Right? So this is in brief about what happens in pre-renal, what happens in intrarenal, and what happens in post-renal acute kidney injury, right? Now, what are the things your acute renal failure can lead to, right? First thing, it can lead to uremia, right? Your urea level is going to increase, right? Now, increased urea itself can give you many symptoms like anorexia, nausea, vomiting, right? Apart from that, it can lead to hyperkalemia. Most serious complication of your acute renal failure is hyperkalemia, right? Now we need to understand why exactly acute renal failure will lead to hyperkalemia. The GFR is reduced, right? GFR is reduced, so less solute is getting filtered, right? Less solute is getting filtered. Less solute, less solute, less solute, and less solute is reaching over here, right? And over here, what you have got? You have got in collecting duct ENaC channels. Now these ENaC channels are going to absorb less sodium, right? Lot less sodium because less solute is reaching these ENaC channels. Your ENaC channels are going to reabsorb less sodium, right? Since they are reabsorbing less sodium, you will have less negative charge on this side, right? Since there is less negative charge on this side, the pull which was earlier pulling the potassium towards it, that pull will be less, right? Since less potassium is going, since less sodium is going this side, less potassium will come out, right? This negative charge was actually pulling the potassium out, right? But since less sodium has gone out, this negative charge will reduce, right? This negative charge will reduce, so less potassium will come out. If less potassium comes out, you will of course get hyperkalemia, and this is the most serious complication, right? Hyperkalemia. Apart from that, what else you can get in acute renal failure, right? You also get what we call hypocalcemia, right? Why exactly the hypocalcemia is going to happen in acute renal failure, right? If you recall my previous videos, right, where exactly the final step of vitamin D synthesis happens, it happens inside your PCT, right? And here we are having ischemic damage of PCT, right? Since there is ischemic damage of PCT, the final step of vitamin D synthesis won't be happen, and vitamin D is something which is helping in reabsorption of calcium from the intestine, right? Since vitamin D, final step of vitamin D synthesis won't happen, so calcium level are going to reduce. Other reason is the phosphate level rise. Why phosphate level rise? Because less blood is coming to your glomeruli, right? So less phosphate filtration, less phosphate excretion. So the phosphate level rises, right? And some calcium combines with the phosphate also. So this also reduces the serum calcium. But main reason is lack of vitamin D synthesis because of damage in the PCT, right? Hyperkalemia, and apart from hyperkalemia, you will have hypocalcemia. And hyperphosphatemia. Right? And of course you will have acidosis, right? One of the main jobs of kidney is to secrete out the excess H plus ions, right? And since your kidney is hypofunctioning, this function will get impaired. H plus won't be secreted out, and this will lead to acidosis, right? But as a doctor, which complication you are most worried about? This is your hyperkalemia. You're most worried about this, hyperkalemia, right? So in this case, first you will stabilize the cardiac membrane by giving calcium gluconate. Why hyperkalemia is so dangerous? Because it can lead to cardiac arrest. So first you will give your calcium gluconate to stabilize the cardiac membrane, then you will give insulin, right? And fluid infusion, etc., right? So in this is in brief about the pre-renal, right, intrarenal and post-renal acute renal failure or acute kidney injury, right? So let's sum it up. What actually is acute renal failure or acute kidney injury, right? Sudden deterioration of renal function which happens over hours or days, right? In many cases it can be reversible, right? And what is the criteria? Rise in serum creatinine more than 0.3 gram per deciliter within 48 hours, right? Rise in serum creatinine more than 0.3 gram per deciliter within 48 hours, right? Is one of the criteria for acute kidney injury, right? And we divide this acute kidney injury into three varieties depending upon their causes, right? One variety is pre-renal, that means the blood volume which is coming to the kidney itself is not sufficient, right? It can be due to hypovolemia, right? Hypovolemia itself can be due to hemorrhage, right? Or due to loss of fluid from GIT like diarrhea, or dehydration due to loss in sweat or less water intake. Other thing is effective circulating blood volume. That means overall blood volume may be normal, but the blood volume which is actually reaching the kidneys can be less. It can be due to heart failure, right? It can be due to cirrhosis, which we discussed, and it can be due to sepsis. Other thing is renal artery stenosis. If renal artery itself get stenosed, right? And it can be also due to drugs like AC inhibitors, which are going to dilate your efferent arteriole and reduce the pressure inside the capillaries, or due to NSAID, which are going to inhibit the prostaglandins and constrict your afferent arteriole, right? So initially body will somehow try to manage by dilating the afferent arteriole, constricting the efferent arteriole, but if this condition persists, it will lead to fall in the pressure inside the glomerulus and GFR, and this can further lead to ischemic injury. And fall in the pressure inside the glomerula can stimulate your renin system, can stimulate your sympathetic nervous system, can stimulate the ADH release, which leads to sodium and water retention, which often leads to vicious cycle in case of heart failure, right? Apart from that, there is something called intrarenal acute kidney injury. Now in intrarenal acute kidney injury, we divide it into ischemic and toxic, right? The PCT, being the metabolically most active part of the nephron, is always on the verge of hypoxia, but just in case the blood supply reduces, right, it enters into hypoxia proper, right? Less oxygen means less ATP production inside the mitochondria. Less ATP production means the sodium potassium ATPase pump gets less ATP for its function, right? And your cells are going to swell up because of the sodium accumulation inside the cell, and this will produce the chaos inside the cell. The cellular polarity and cellular architecture will be gone. This will lead to mitochondrial dysfunction, which is going to release reactive oxygen species. There will be calcium dysregulation also, which is going to activate your phospholipase and endonuclease. This is going to damage your membranes. All this membrane will slough off and get deposited inside your tubules, which is often called TAM horsefall proteins, right? This TAM horsefall proteins, after depositing, will increase your intratubular pressure. This backflow is going to further reduce your GFR, right? Then there is something called toxic cause of your intrarenal damage. This rhabdomyolysis, massive hemolysis, aminoglycosides, right? All these will get reabsorbed in the PCT, right? And they will themselves cause mitochondrial dysfunction. And the same cycle will repeat, and ultimately GFR will reduce further. Then there is something called post-renal acute kidney injury. In post-renal acute kidney injury, the ureteric stones, the benign prostatic hyperplasia, right, or constriction of the neck of the bladder, right? So this will increase the pressure inside your urinary tract, which will be transmitted to the kidneys, and this will further reduce your GFR, right? But just in case, if you remove the obstruction, right, you will have post-obstructive diuresis. Why? Because the solutes have deposited, right? And also because the filtering ability of the kidneys is lost for some time, right? So this gives about post-renal acute kidney injury. Now what are the things you are going to find? Ultimately in acute kidney injury, you will find uremia, right? So you will get uremic symptoms like anorexia, vomiting, right? You will get hyperkalemia. Why you will get hyperkalemia? Because less solute is reaching over here, less reabsorption from sodium via the ENaC channels, and less secretion of potassium. If less secretion of potassium, this means hyperkalemia, right? Since the less blood is coming, so less phosphate is filtered out, right? So you will have hyperphosphatemia, but you will have hypocalcemia. Why hypocalcemia? Because the last step of vitamin D synthesis, 1-alpha hydroxylation, actually happens inside the PCT, right? If this gets damaged, if your PCT gets ischemic damage, right, then the this thing, vitamin D won't be formed and calcium won't be reabsorbed from the intestine, right? And of course, since the kidney is hypofunctioning, you will have acidosis. But the most important complication is hyperkalemia, right? For that you will give calcium gluconate for stabilizing the cardiac membrane, right? And you will also give insulin and fluid therapy, right? So hopefully this video has helped you in better understanding of the acute renal failure or acute kidney injury and better understanding of the overall mechanism behind it, right? Wish you all the very best. Thank you.